Prostate cancer remains one of the most common malignancies among men worldwide. Early detection and accurate risk assessment are crucial for improving outcomes and reducing unnecessary treatments. Biomarkers have revolutionized the way we approach prostate cancer, offering new tools for diagnosis, prognosis, and monitoring. In this video, we'll explore the evolution of prostate cancer biomarkers, from the discovery of PSA to the latest advances in molecular and genetic testing. We'll also discuss how these biomarkers are changing clinical practice and what the future may hold for patients and clinicians alike. Prostate-specific antigen, or PSA, is a protein produced by prostatic epithelial cells. Since its discovery in 1979, PSA has become the cornerstone of prostate cancer screening and monitoring. For PSA testing, prostate cancer was often diagnosed at an advanced, incurable stage. Today, most cases are detected earlier, thanks to modest elevations in PSA level. However, PSA is prostate-specific but not cancer-specific, meaning that benign conditions like BPH or inflammation can also raise PSA levels. This lack of specificity has led to concerns about overdiagnosis and unnecessary biopsies, prompting the search for more accurate biomarkers. While PSA testing has reduced prostate cancer mortality, its poor specificity has significant drawbacks. Many men with elevated PSA do not have cancer, leading to frequent false positives and unnecessary biopsies. Conversely, some aggressive cancers may not cause a significant PSA rise, resulting in misdiagnoses. The balance between benefit and harm has been debated, and at one point, the U.S. Preventative Services Task Force recommended against routine PSA screening. This controversy has driven innovation in biomarker research, aiming to improve specificity and reduce overtreatment. The better understanding of prostate cancer biology, especially the indolent nature of many low-grade tumors, active surveillance has become a safe and effective management strategy for low-risk cases. This approach reduces overtreatment and its associated harms. At the same time, guidelines now recommend secondary testing with imaging or additional biomarkers before proceeding to biopsy in men with elevated PSA. These changes reflect a shift toward more personalized and precise care, using biomarkers to guide decision-making and avoid unnecessary interventions. Prostate cancer biomarkers are now used in three main clinical settings: early detection of significant cancer, risk stratification for newly diagnosed cases, and post-treatment monitoring. Early detection biomarkers help identify men at highest risk, reducing unnecessary imaging or biopsies. For those already diagnosed, biomarkers assist in distinguishing who may benefit from active surveillance versus immediate treatment. After treatment, biomarkers can guide decisions about adjuvant or salvage therapies, especially in men at risk for recurrence or metastasis. This multifaceted approach aims to improve outcomes while minimizing harm. Biomarker discovery is rooted in understanding the biological differences between cancerous and benign prostate cells. At the molecular level, this involves changes in DNA, RNA, and protein expression. Cancer cells often exhibit unique genetic mutations, altered gene expression, and distinct protein profiles. By identifying and measuring these differences in tissue or bodily fluids, researchers can develop biomarkers that are more specific to cancer, improving detection and risk assessment. This scientific foundation underpins the ongoing evolution of prostate cancer biomarkers. Development of prostate cancer biomarkers has progressed through several generations. First-generation markers like PSA are specific to the prostate but not to cancer. Second-generation markers such as PCA3 and kallikrein family proteins are more cancer-specific and can better distinguish malignant from benign conditions. Third-generation biomarkers like SCH-LAP1 are associated with high-grade aggressive cancers and hold promise for identifying patients at greatest risk. This evolution reflects a growing ability to tailor screening and treatment to individual risk profiles. Developing a clinically useful biomarker is a complex, multi-phase process. It begins with discovery in the laboratory, followed by validation in increasingly representative patient populations. The Early Detection Research Network (EDRN) has established a rigorous framework for biomarker development, involving collaboration between academic centers, industry, and public health groups. Each phase, from initial discovery to large-scale clinical validation, builds evidence for the biomarker's accuracy, reliability, and clinical utility. Only a few biomarkers make it through this demanding process to become part of routine care. Journey from biomarker discovery to clinical use involves 5 key phases. Phase 1 is discovery, identifying promising candidates. Phase 2 focuses on measuring sensitivity and specificity in relevant populations. Phase 3 evaluates the biomarker's ability to detect preclinical disease and defines test thresholds. Phase 4 involves prospective validation in the target population, quantifying performance metrics like sensitivity, specificity, and predictive value. Finally, Phase 5 assesses the biomarker's impact on cancer control, including reductions in mortality and cost-effectiveness. This structured approach ensures that only the most effective biomarkers reach clinical practice. For a biomarker to be widely adopted, it often needs approval from regulatory bodies like the U.S. Food and Drug Administration (FDA). FDA approval signifies that a biomarker is valid and safe for a specific clinical use. However, many tests are offered as laboratory-developed tests (LDTs) in CLIA-certified labs, which ensures quality but not necessarily clinical validity. Currently, FDA-approved prostate cancer biomarkers include PSA, percent-free PSA, prostate health index (PHI), and PCA3. Understanding the regulatory landscape helps clinicians and patients interpret test results and make informed decisions. Once a biomarker is developed, its performance must be rigorously assessed. This process, known as validation, involves evaluating the test in both internal and external cohorts. Internal validation uses the same data set as development, while external validation tests the biomarker in a new, real-world population. Key performance metrics include discrimination, how well the test distinguishes between those with and without disease, calibration, agreement between predicted and observed outcomes, sensitivity, specificity, and predictive values. These measures help determine the clinical value of a biomarker. Discrimination refers to a biomarker's ability to correctly distinguish between patients who do and do not have the outcome of interest, such as clinically significant prostate cancer. It's often measured by the area under the ROC curve (AUC), with higher values indicating better performance. Calibration, on the other hand, measures how closely the predicted risks match actual outcomes. A well-calibrated model ensures that, for example, if a group of patients is predicted to have a 20% risk, about 20% actually do. Both discrimination and calibration are essential for a reliable biomarker. Sensitivity is the proportion of true positives detected by the test, while specificity is the proportion of true negatives. High sensitivity means few cases are missed. High specificity means few false alarms. Positive predictive value (PPV) and negative predictive value (NPV) are more patient-centered, indicating the likelihood that a positive or negative test result reflects the true disease status. These values depend on disease prevalence in the tested population. Understanding these metrics helps clinicians interpret test results and communicate risks to patients. Beyond accuracy, a biomarker's clinical utility is about its real-world impact. Does using the test improve patient outcomes, reduce unnecessary procedures, or help guide treatment decisions? Clinical utility weighs the benefits and harms of testing, considering not just the numbers but the practical consequences for patients and healthcare systems. Decision curve analysis is one method used to evaluate net clinical benefit across different risk thresholds. Ultimately, a biomarker must demonstrate both validity and utility to become a standard part of care. PSA, or human kallikrein-3 (HK3), is the most established biomarker for prostate cancer. It's a serine protease produced by the prostate and released into seminal fluid and, to a lesser extent, the bloodstream. PSA exists in both free and complex forms in serum. Its levels are influenced by age, prostate volume, inflammation, and manipulation, not just cancer. Despite its limitations, PSA remains the first-line test for screening and monitoring, laying the groundwork for understanding and developing more advanced biomarkers. The bloodstream, PSA circulates in several molecular forms: free PSA, complex PSA bound to proteins like alpha-1 antitrypsin and alpha-2 macroglobulin, and various isoforms. The majority is complex, but the ratio of free to total PSA can provide additional diagnostic information. Cancer tends to lower the percentage of free PSA, leading to the development of tests that measure this ratio. Understanding these molecular forms has paved the way for more nuanced and accurate biomarker assays. PSA levels can be influenced by many factors beyond cancer. Benign prostatic hyperplasia (BPH), prostatitis, recent prostate manipulation, and even activities like long-distance cycling can cause temporary increases. Medications such as 5-alpha-reductase inhibitors can lower PSA by about 50%. Age, race, and prostate volume also play roles. Clinicians must interpret PSA results in the context of these variables to avoid misdiagnosis and unnecessary interventions. PSA velocity, or the rate of change in PSA over time, was once thought to be a useful predictor of cancer risk. However, recent studies show it has limited value for screening. PSA density, calculated as PSA divided by prostate volume, provides more predictive information. Lower PSA density is associated with lower risk, and higher density may indicate a need for biopsy. These refinements help improve the specificity of PSA-based testing. Free PSA makes up 45% of total PSA in serum. Cancerous prostate tissue tends to produce less free PSA, so a lower percentage of free PSA percent FPSA is associated with higher cancer risk. Testing percent FPSA can improve the accuracy of prostate cancer screening, especially in men with intermediate PSA levels. Various thresholds have been proposed, generally between 15–25%, to help decide when a biopsy is warranted. This approach reduces unnecessary biopsies while maintaining high sensitivity for cancer detection. PSA in serum includes several isoforms: pro-PSA, benign PSA, BPSA, and intact PSA, iPSA. Pro-PSA, especially the 2-pro-PSA isoform, is more prevalent in cancerous tissue and has been incorporated into new biomarker tests. BPSA is associated with benign prostatic hyperplasia, while iPSA may improve cancer detection when used in combination with other markers. Understanding these isoforms allows for more targeted and accurate testing. Pro-PSA, particularly the 2-pro-PSA isoform, is a promising biomarker for prostate cancer. It is often elevated in cancerous tissue and correlates with higher Gleason scores. The Prostate Health Index (PHI) combines 2-pro-PSA, free PSA, and total PSA into a single score that better predicts the presence of clinically significant cancer. Studies show that PHI outperforms PSA alone, improving both sensitivity and specificity. PSA is now included in clinical guidelines for risk stratification before biopsy. IsoPSA is a novel, structure-based assay that partitions PSA isoforms associated with cancer. By analyzing the molecular structure rather than just concentration, IsoPSA provides improved sensitivity and specificity for detecting high-grade prostate cancer. Its performance is unaffected by medications like 5-alpha reductase inhibitors, making it a reliable option for many patients. IsoPSA is now recommended in guidelines for risk assessment before prostate biopsy. 4K score test is a blood-based panel that measures 4 prostate-specific kallikreins, total PSA, free PSA, intact PSA, and HK2, along with clinical factors like age and DRE findings. This multivariable model estimates the probability of clinically significant cancer on biopsy. Studies show that the 4K score can reduce unnecessary biopsies while maintaining high sensitivity for aggressive cancer. It is especially useful for men with intermediate PSA levels and is included in current clinical guidelines. Circulating tumor cells, CTCs, and circulating tumor DNA, ctDNA, offer non-invasive ways to monitor prostate cancer. CTCs can predict prognosis and response to therapy, especially in advanced disease. The FDA-approved cell search system identifies CTCs in blood, and higher counts are linked to poorer outcomes. ctDNA analysis provides insights into tumor genetics and resistance mechanisms, helping guide treatment decisions. These liquid biopsy approaches are rapidly evolving and hold great promise for the future. Urine-based biomarkers are attractive due to the ease of sample collection. PCA3 is a long non-coding RNA highly overexpressed in prostate cancer tissue. It is detected in urine after a digital rectal exam and provides improved sensitivity and specificity over PSA alone. PCA3 scores help guide biopsy decisions, especially in men with previous negative biopsies. While not perfect, PCA3 represents a significant advance in non-invasive prostate cancer detection. SelectMDx is a urine-based test that measures mRNA levels of DLX1 and HOXC6, combined with clinical factors, to estimate the risk of prostate cancer and high-grade disease. It offers high sensitivity and negative predictive value, helping to avoid unnecessary biopsies. SelectMDx is especially useful for men with elevated PSA but no prior imaging, and it is included in current guidelines for risk stratification before biopsy. ExoDx Prostate IntelliScore (EPI) test analyzes exosomal RNA in urine, focusing on 3 biomarkers: PCA3, ERG, and SPDEF. Exosomes are small vesicles that carry genetic material from cells, making them a rich source of biomarkers. EPI provides a numerical score associated with the likelihood of high-grade prostate cancer, helping to guide biopsy decisions. It does not require a digital rectal exam and is validated for use in both initial and repeat biopsy settings. PS combines urinary PCA3, TMPRSS2 or gene fusion, and serum PSA into a single model that predicts the risk of clinically significant prostate cancer. This test provides a continuous score from 0 to 100, with higher scores indicating greater risk. MPS has been validated in large studies and shown to reduce unnecessary biopsies while maintaining high sensitivity for aggressive cancer. It is now part of recommended biomarker panels for early detection. MicroRNAs, miRNAs, are small non-coding RNA molecules that regulate gene expression. Certain miRNAs, like miR141 and miR187, have been associated with prostate cancer and aggressive disease. While panels of miRNAs show promise for both diagnosis and prognosis, their clinical use is still under investigation. Ongoing research aims to validate these markers and integrate them into routine testing. Epigenetic modifications, such as DNA methylation and histone acetylation, can alter gene expression without changing the underlying DNA sequence. In prostate cancer, hypermethylation of genes like GSTP1, APC, and RSSF1A is common and can be detected in tissue samples. Commercial assays like ConfirmMDx assess methylation status to help identify patients at risk for occult cancer after a negative biopsy. These tests provide additional information beyond traditional pathology. Advances in genomics have enabled the development of tests that assess the expression of multiple genes in prostate tissue. Commercially available assays like Prolaris, Oncotype DX Prostate, and Decipher analyze gene signatures associated with aggressive disease features. These tests help guide management decisions, such as choosing between active surveillance and definitive treatment. While promising, their use must consider tumor heterogeneity and is best interpreted alongside clinical and pathological data. Prolaris test measures the expression of 31 cell cycle progression genes and 15 housekeeping genes in prostate tissue. Studies show that the Prolaris score predicts the risk of progression and death from prostate cancer, providing independent prognostic information. It can be used to refine risk assessment in both conservatively managed and surgically treated patients, helping to personalize treatment strategies. Oncotype DX Prostate analyzes the expression of 12 cancer-related genes and 5 housekeeping genes to predict the likelihood of aggressive pathological features at prostatectomy. This information helps clinicians and patients decide between active surveillance and immediate treatment. The test has been validated in diverse populations and is increasingly used in clinical practice to support shared decision-making. Decipher assay evaluates the expression of 22 genes to predict the risk of metastasis and prostate cancer-specific mortality after prostatectomy. It is particularly useful for men with high-risk disease or biochemical recurrence, guiding decisions about adjuvant or salvage radiation therapy. Decipher is also being studied for use in newly diagnosed patients to assist with initial management choices. While tissue-based genomic tests provide valuable prognostic information, they face challenges related to tumor multifocality and heterogeneity. Different areas of the same prostate may have varying gene expression profiles, potentially affecting test accuracy. Most validation studies are retrospective, and ongoing prospective trials aim to clarify the best use of these assays. Clinicians should interpret results in the context of the entire clinical picture. Half of prostate cancer risk may be related to hereditary factors. Having a family history of prostate cancer increases risk, and certain genetic variants, such as single nucleotide polymorphisms (SNPs), further elevate this risk. The STHLM3 test combines kallikrein markers (SNPs) and clinical variables to improve early detection. Understanding genetic risk can help identify men who may benefit from earlier or more intensive screening. Mutations in DNA damage repair genes like BRCA1, BRCA2, and ATM are associated with a higher risk of aggressive prostate cancer. Men with these mutations are diagnosed at younger ages and often have more advanced disease. Multigene panel testing is now available, and guidelines recommend BRCA testing for men with a strong family history or high-risk features. Identifying these mutations can influence screening and management strategy. Other genes, such as CHEK2 and HOXB13, also contribute to hereditary prostate cancer risk. The HOXB13G84E variant, for example, increases risk by more than fourfold. While these markers are less common than BRCA mutations, they are important in certain families and may be included in multigene panels. Ongoing research is clarifying their role in risk assessment and clinical management. Next-generation sequencing (NGS) allows for comprehensive analysis of multiple genes simultaneously. NGS-based panels are now used to assess hereditary risk and guide treatment decisions, especially in advanced or high-risk cases. These panels typically include BRCA1, BRCA2, ATM, CHEK2, and mismatch repair genes. While some genes have well-established clinical significance, others are still being studied. NGS is rapidly becoming a standard tool in precision oncology. The field of prostate cancer biomarkers is advancing rapidly, with new tests offering improved accuracy for early detection, risk stratification, and monitoring. Panels that combine multiple markers are likely to provide the best balance of sensitivity and specificity, helping to overcome challenges posed by tumor heterogeneity. Ongoing research and clinical trials will continue to refine these tools, ensuring that they deliver real benefits to patients and clinicians. The ultimate goal is to improve outcomes while minimizing unnecessary interventions. Let's recap the key points. PSA remains the foundational biomarker but is not cancer-specific. Newer blood, urine, and tissue-based biomarkers improve specificity and help guide clinical decisions. Genetic and genomic testing is increasingly important for risk assessment and personalized care. Clinical utility, not just accuracy, determines the value of a biomarker. As research progresses, integrating multiple biomarkers will likely become the norm in prostate cancer management. Your clinical guidelines now recommend the use of validated biomarkers for risk stratification before prostate biopsy. Tests like Phi, 4K-score, IsoPSA, PCA3, SelectMDx, ExoDx, and are included in the 2023 NCCN Prostate Cancer Early Detection Guideline. These tools help clinicians and patients make more informed decisions, reducing unnecessary procedures and focusing attention on those at highest risk. Shift toward biomarker-driven care reflects a broader movement in medicine toward patient-centered decision-making. By integrating biomarker results with clinical findings and patient preferences, clinicians can tailor screening and treatment plans. This approach aims to maximize benefits, minimize harms, and respect individual values. As more biomarkers become available, shared decision-making will become even more central to prostate cancer care. Research into prostate cancer biomarkers is ongoing, with new discoveries on the horizon. Liquid biopsy technologies, advanced genomics, and artificial intelligence are poised to further improve detection and risk assessment. Prospective clinical trials will help determine the best ways to integrate these tools into practice. The future promises more precise, less invasive, and more effective management of prostate cancer. Conclusion: prostate cancer biomarkers have transformed the landscape of diagnosis and management. From PSA to cutting-edge genomic tests, these tools enable more accurate, individualized care. As technology advances, the integration of multiple biomarkers and clinical data will usher in a new era of precision oncology. The ultimate goal is to detect cancer early, treat it effectively, and spare patients from unnecessary harm. Thank you for joining us on this journey through the evolving world of prostate cancer biomarkers.